Good morning, everyone. I'm Jim McCracken, Director of the Child Psychiatry Division, and it's an honor and pleasure to introduce the 23rd Annual Cantwell Memorial Lectureship with our distinguished speaker, Dr. Cynthia Rogers. First, just a brief intro about the Cantwell Lectureship. This lectureship invites a leading researcher in the field of child mental health for a lecture on critical issues in child mental health research and treatment, enhancing the care, the treatment of children with mental disorders, and furthering the scientific basis of child psychiatry. Dr. Cantwell was a distinguished member of the Department and Child Division faculty. He was the training director of our Child Psychiatry Fellowship for 20 years, which I believe is the longest tenure of the fellowship director to date. He's well known as a leading researcher and educator whose research spanned an amazing array of topics, from groundbreaking studies on classification of childhood mental disorders, disruptive behavior disorders, follow-up studies of communication and learning disorders, eating disorders, pervasive developmental disorders, and perhaps he's best known for his family genetic studies of ADHD. It's hard to describe how beloved Dr. Cantwell was by his students and other professionals for his incomparable teaching style, peppered with wit, amazing hilarious stories, and an absolute mastery of his subject matter. Dr. Cantwell was born in East St. Louis and received his MD and general psychiatry training at Washington University of St. Louis. He trained at child psychiatry at UCLA and joined the faculty in 1972. Dr. Cantwell's family, friends, and colleagues have established this program to honor his spirit and accomplishments and to acknowledge the achievements of other remarkable child mental health researchers. So it's a delight, and Dr. Cantwell would be tickled to have Dr. Rogers here today as the memorial lecturer with the connection with Wash U. Dr. Rogers is professor and director of the Division of Child Psychiatry at Washington University. She's also associate director of the Wash U IDDRC, associate director of the Center for Study of Race, Ethnicity, and Equity, and a groundbreaking researcher in her field of early childhood brain function and psychopathology. She's the author of over 70 publications, has been honored by the recipient of a Career Development Award from the WashU CTSI, recently was designated as the National Academy of Medicine Emerging Leader in Health and Medicine Scholar. So it's fantastic, Dr. Rogers, that you were able to join us today. Delighted, looking forward to your talk today on social determinants of health, impact on brain connectivity in early childhood psychopathology. Welcome.
Thank you. Thank you so much for having me. First, I want to say how honored I am to be giving a lecture named after Dr. Cantwell, who was truly one of the pioneers in child psychiatry research. He helped elucidate, both psychological and biological mechanisms of developmental psychopathology. And the work I will be presenting today certainly builds on our understanding of these mechanisms and is also focused on how social structures impact those same mechanisms. So I'm going to talk to you today about how addressing social determinants can optimize infant brain development. And hopefully you all are seeing everything. These are my disclosures. So just a brief roadmap for today. First, just to talk about social determinants of health in general, and then to talk about how social determinants of health impact brain development, our infant brain development, and then some of the ways that, at least here, we're going about trying to address some of the social determinants of health. So to begin, when we think about social determinants of health, we're really thinking about sort of things that fall into these various categories. And one of the things that, I was kind of, pretty surprised to find out, a few years ago was that when we account for social determinants of health, we are really accounting for 75% of the variance in health outcomes. And so as folks that are really interested in improving health, it's really important that we, have a lens toward how we might address these social determinants of health within our patient population. You can't really talk about social determinants of health without addressing health disparities and addressing racism and discrimination that go along with them, along with the several structures that underlie social determinants of health. And so as we think about all of these different systems, we know that racism and discrimination cut across all of these factors. And when asked, we find that Americans of color report more social determinants of health impacting their local communities, although it's, as you can see here, it was more than half really of everyone that was asked. So social determinants of health really are impacting a lot of our communities, but definitely more so for our minoritized populations. If we start at the sort of the beginning of this figure and think about various things that make up socioeconomic status, education, employment, income, poverty, and the red arrows indicate those that are amplified by racial biases. And then we looked at the sort of, certain selection of social determinants of health, things like the neighborhood, housing quality, access to healthy food, for instance, and we know that those too are also impacted, those also are amplified by racial biases. So they all come together in a way that link poverty, social determinants, and then the health outcomes that we're interested in. In our lab, we really think about socioeconomic status as being the hub of a wheel of factors that explain why there's such a relationship between socioeconomic status and, in our case, what we're focused on, mental health outcomes. And so I've listed here a lot of the various factors that we think are really important to assess and measure when thinking about how poverty is related to the mental health outcomes that we are all interested in impacting. In addition to poverty, there are other factors that are important to think about, like, as was mentioned with Dr. Cantwell and ADHD, family history and genetics, as well as how there's an interaction between those things like family history, socioeconomic status, as well as how they impact both prenatal and postnatal stress, and how those impact development of the brain, both in utero and then across development, and lead to some of the poor developmental outcomes in our children. So if we start first with early brain development, a significant amount of early brain development occurs during the third trimester. And this movie here is takes 3D reconstructions of some of our infants that were scanned during what would have been the third trimester. And what you can see is, significant growth, not only in volume, but also in the complexity of cortical folding. And it's because of this rapid development that occurs during the third trimester that we think that the immature brain is much more vulnerable to the environment. And we'll talk a little bit more about what we think some of those mechanisms may be in a moment. But postnatally, there's still a significant amount of brain development that occurs. If you start on the left side of the screen, where you have the neonatal brain, that at birth is about a quarter of the adult size. But by 1 year of age, we're already at 70% of adult size, along with significant myelination having occurred in the white matter, as well as more complex folding in the gray matter as well. And then by 2 years, we're at 80% of adult size. So you can see there's just been this really massive amount of brain development that's occurred postnatally, again, at a time that might make this postnatal brain vulnerable to the ex utero environment. Potential biological mechanisms that may explain how things like exposure to psychosocial stress, during pregnancy as well as postnatally can lead to how these social determinants are impacting the developing brain are noted here on the slide. And if you start on the left with prenatal exposures, you see a lot of various pathways, some of which we've been investigating in our lab, including things like cytokines, cortisol, as well as the microbiome, both the vaginal and gut microbiome, that can then impact fetal development and brain maturation. And then postnatally, a lot of those same mechanisms are at play within the child themselves, but also epigenetic mechanisms can also come into play postnatally as well. And so just taken together, you can see there are several different mechanisms that can be working either in isolation or together to link some of the social determinants that the prenatal infant is exposed to, as well as postnatal. There were earlier studies that really began to look at how things like poverty were impacting infant cortical gray matter development. So this first one at the top was in 5-week-old infants, and you can see as SES increased in their cohort, cortical gray matter volume increased as well. So, and then similarly, a little bit earlier, another study looked at those that had low, mid, or high socioeconomic status and found that across time, as the brain continued to develop, there really were decreases in cortical gray matter volume up to 3 years of age. More recently, a study by Amy Margulis at Columbia looked at hippocampal and amygdala volume specifically, and looked at a measure called the income to needs ratio, which basically is looking at family income versus family size, and gives a sense of whether or not the income is meeting the family's needs, with income to needs ratio of 1 indicating the poverty line, the federal poverty line. What you can see here is that infants that were exposed to poverty earlier, like 6 months of age, were more impacted by, in terms of hippocampal volume, being lower than those who had a higher income to needs ratio. And it really was these earlier time points, like at 6 months of age, that were more impacted than when you looked at ages 3 or 7, when the exposure to poverty happened later in childhood. So our lab has several ongoing longitudinal studies where we are assessing perinatal psychosocial factors, social determinants, and infant brain development. I won't go over all of these today, but I'll start with our longest running study, our study of preterm birth, as well as discussing a multi-lab study we're involved in called the E-Lab study, which is looking at prenatal poverty and stress exposure, and then our CUDDEL study, which is looking at prenatal cannabis exposure. Among our study cohorts, the demographics are kind of listed here, and just to give you a sense of the population that we tend to study tends to be at least half, if not majority, Black. A good proportion are on Medicaid or below the poverty line. So we, recruit our cohorts from our medical center, which is in urban St. Louis, and so our populations tend to reflect the population that our medical center serves. Now, preterm birth has been linked to poverty for a number of years. This graph here just shows you those in blue who were in poverty had higher rates of preterm birth across the years compared to those who were not. And even as preterm birth rates declined, they still were at a higher level among those who were in poverty. However, unfortunately, preterm birth rates have now been going back up again. So once again, poverty is really a significant risk factor for preterm birth. Interestingly, there's this proposed cycle explaining how preterm birth and poverty are linked, with an adult beginning with an adult in poverty who then is exposed to the toxic stress that comes from a lot of things associated with poverty in this country, which then leads to a whole host of these biological mechanisms leading to preterm birth. And then the premature child is continuing to be exposed to that same toxic stress and other aspects of poverty, leading to structural and functional brain changes, which, and then again, leads to impaired neurodevelopment, and then decreased educational attainment, and then the cycle starts over again. So this is, obviously not the case for every child born into poverty or every preterm child, but does give I think, a good theoretical basis for how poverty and preterm birth are linked. Another well-known factor related to preterm birth is that those that are of African or African American race or ethnicity have higher rates of preterm birth, regardless of socioeconomic status. And so this study was really interesting because it found that it was actually those Black moms who had more stress from exposure to racism who really had the elevated rates of preterm birth, and compared to those moms who did not express that same stress from racism, suggesting that racism may explain why we see some of these differences, particularly in this country, around preterm birth. And they further explained the sort of upstream causes related to systemic and structural racism, down to the midstream, which are more some of the social determinants that we talked about, that lead to some health harming conditions and exposures, leading to these biological mechanisms, and then ultimately preterm birth disparities. So I think we really thought that prematurity, preterm birth was really a good model for us to really think about the impact of social determinants on the developing brain. What we do know about the preterm brain is that it's very different than the full-term brain, particularly when you're studying the infants that we study, which are those that are very preterm, those that are born 30 weeks gestation or less. What you can see here, even without being a neuroradiologist, is that the full-term brain is very different in terms of the volume and the complexity of folding compared to the preterm brain. And these infants from our study were both scanned around the same time. So even though the preterm child was born earlier, this scan was conducted at the time they should have been born. So more of an apples to apples comparison, but you can see just a significant difference in brain development in these 2D images. And then when we showed these 3D reconstructions, you see the 5 preterm infants on the right side of the screen, really some very significant alterations in their brain development, some more than others, which may explain some of the variability that we see in outcomes in preterm children. Regardless, it's challenging to see how any of those brains will end up developing into the typical adult brain, which we have here. Prematurity has long been known to increase the risk of psychiatric disorders, which is another reason why, as a child psychiatrist, I've been very interested in studying it, and I also see these children clinically. So we know from several years of study, but this is just one illustrative study that showed that preterm infants, particularly born at the earliest gestational ages, had higher rates of childhood psychiatric disorders overall, but particularly of ADHD, anxiety, and autism, which when you take all those together, has been termed the preterm behavioral phenotype, this kind of combination of social communication, attention or ADHD or executive function impairments, as well as internalizing symptoms. So our study of prematurity has been going on since 2007, when these infants were recruited at birth, and then a term cohort was recruited at the adjoining maternity hospital. They were all scanned at the time that they should have been born or at birth for the term children, and then returned at ages 2 years, 5 years for developmental assessments and assessments of psychiatric symptoms. And then at age 10, which we were just finishing up, they were scanned again and continued assessment of their development. And we were recently renewed to bring the children back at ages 14 and 15, which is just starting, where we once again scan the children as adolescents and continue to assess their psychiatric symptoms. Now, for those who do not do neonatal scanning, it may sound like a really challenging endeavor, but as a lab that now scans neonates, 2-year-olds, 3-year-olds, and school-age children, I can tell you that neonates are the easiest age to scan by far. We have the caregiver feed them, they're then swaddled, and then put in this, what we call a papoose, and they sleep and we put them in the scanner. So for some of the preemies, they even would go in if they were fairly ill still in the incubator, but at the term equivalent scan, when they should have been born, most of them by then were just placed in a normal head coil. We assess several different measures from our MRI images. I'm just going to review two of the main ones. And forgive me for those of you all that are experts in functional connectivity. This will seem very simplistic, but I thought it'd be helpful for those who don't do this work. So with fMRI, we assess what we call the bold signal, which is sort of a proxy for brain activity. But if you think about the entirety of these circles together, these ovals together being the brain, and then you have various ovals that are active at various times, then you can ask, well, I wonder when this particular region is active, if there are other regions that are active at the same time. And when you do that, you correlate activity across the brain, and you find that there are these temporal correlations, all of those in yellow, that are sort of changing their bold signal up and down together. And so this other figure down here from Mike Fox, who was a medical school colleague of mine, shows that the regions in the warm regions, the posterior cingulate cortex and medial prefrontal cortex, are both temporally changing their signal together, whereas those that are the cool colors are almost changing in the opposite direction. And so that's how we, in a very simplistic way, get resting state functional connectivity measures, and then that allows us to assess functional brain networks. And so I listed some of those here. And so these are areas of the brain that work together to conduct certain processes. And we assess brain structural connectivity by diffusion tractography, for the most part in our lab. And so listed here a couple of the tracks that we're most interested in because of their relationship with psychopathology. But we get measures, diffusion measures, one called fractional anisotropy, or FA, which is the degree that diffusion deviates from the sphere, so sort of that long axis, and then mean diffusivity, which is the overall diffusion. And so that helps us understand how the tracks are developing. So I'm going to review what has been several years of work very quickly in this one slide. But starting off with Pepper Sear, who's an MSDP in our lab, about to graduate. This is just to kind of illustrate our findings that have related neonatal functional structural connectivity to later outcomes in childhood. And so Pepper has found that motor cortex connectivity at the time of birth is related to motor skills at age 2. And I should say, as part of her thesis, she's also shown that they are related to motor skills at age 5 and 9 to 10. We've also previously shown that the cingulum bundle, a track of interest, was as well as the amygdala default mode network connectivity, were both related to social skills, attention, and internalizing symptoms, that preterm behavioral phenotype that I mentioned earlier. Rebecca Brady, another MSDP graduating in our lab, took that further and related the neonatal cingulum bundle measures again to that same sort of behavioral phenotype symptoms at age 5, and found that it was particularly from the anterior cingulum. And then Joe Dust, who is research staff but is now getting his PhD in neuroscience, also looked at some of those functional brain networks and particularly found that the ventral attention network, along with its interactions with other networks, were also associated with some of those preterm behavioral phenotype symptoms at age 5 years as well. So overall, just showing that we've found a lot of relationships between the neonatal brain and then later childhood psychopathology. But as I mentioned, we were very interested in how the relationships between the developing brain and subsequent outcome are impacted by some of the social structures that our families are exposed to. And so one of the things we've been really interested in is looking at neighborhood poverty. And we've been doing that through the Area Deprivation Index, which is an index that gives you a number for how much neighborhood disadvantage in a particular census block. So I've put in here the address of the medical center. You can see that We're about average for the state with a state decile of 5, but a little bit more disadvantaged than the average nationally with a national percentile of 60. And these are all of the factors that go into the area deprivation index. So when we looked to see how the area deprivation index related to some of the findings that we got in this developing brain, Bruce Ramphal, who was a student who worked with us for a few summers, who's now a medical student at Harvard, found that connectivity between the striatum, the left amygdala, and the medial prefrontal cortex was related to prenatal exposure to neighborhood poverty in the cohort. So with our preterm cohort, we have found evidence of both structural and functional connectivity being related to neighborhood disadvantage. Didn't show this, but just to summarize, we also found that neighborhood disadvantage was responsible between 14 and 30% of the variance in that preterm behavioral phenotype. And Bruce also found evidence that poverty measures really were mediating the relationship between some of the functional connectivity findings and outcome at age 2. So our preterm study has been helpful in us understanding poverty, but it wasn't really designed for that. Whereas our eLab study, which is a very collaborative study that our lab works on along with Joan Luby, Barb Warner, and Deanna Barch. I should mention I run the lab here, the Wonder Lab with Chris Miser. And this study is of about 400 maternal infant dyads, where the maternal caregiver was recruited during pregnancy in the first trimester. They were then scanned at birth. We also got serum samples and microbiome samples from the mom, and then scanned the infant, and then continued to get serum samples from the child, as well as scans from the infant at 2 years of age, and then again at age 3, as well as assessments of their social and emotional development. So it's a very large study, but that I won't be able to present all the results of from today, but I'll go over a few. And so one of the first things we did was we took a lot of the measures that we were obtaining and created 2 latent variables. One that was a marker of social disadvantage, and another that was a marker of psychosocial stress, made up of the factors here. And while they were related to each other, they were only modestly so really were fairly independent factors. And you can see here that really do both kind of represent a lot of the social determinants of health. So Regina Triplett, who's a postdoc in our lab, found that social disadvantage was globally related to brain volume, both cortical white matter, cortical gray matter, white matter, subcortical gray matter, and cerebellar volume were all related to the degree of social disadvantage, with more disadvantage leading to smaller brain volumes. Ashley Nielsen, another postdoc in our lab, found that these various cortical brain networks here were also the ones that were most predictive of social disadvantage. And so this was, again, neonatal scans. And you can see here both some attentional and control networks, as well as some sensory networks as well, somatosensory networks. Dr. Rachel Lean is a developmental psychologist in our lab, now on her Career Development Award, who similarly found that social disadvantage was related to bilateral structural connectivity across multiple tracks of interest. And so you can see here with these findings that we really are finding that exposure to poverty and all the social disadvantage factors has a really global impact on the developing brain. Now, Dr. Lean has more recently looked at how neonatal brain connectivity is related to executive function at age 2, and found that both social disadvantage, as well as some of those same tracks that were impacted by social disadvantage, as well as the singular porcular and frontoparietal networks, both sort of control networks, were all related to executive function at age 2. Now, we didn't quite find a mediating relationship where the brain mediated the relationship between prenatal social disadvantage and executive function at age 2, but we think it's because social disadvantage works across the brain in so many different ways that we didn't quite pick up with just a few different imaging modalities that are related to executive function at full mediating relationship. But more to come on that as we continue to look at the data, but nevertheless, still finding strong relationships between social disadvantage, the developing brain, and executive function at age 2. A lot of really interesting work that Rebecca Brady has done has been looking at how prenatal crime exposure impacts neonatal connectivity. Unfortunately, St. Louis particular parts really have very high crime rates and very high violent crime. If you look at the left, which is a map of St. Louis with the darker colors representing areas that had higher violent crime rates, you can see that there are several areas that have really significant levels of violent crime. And then we looked at property crime, which is a little bit more dispersed. What she found was that exposure to crime prenatally was related to amygdala, hippocampus, and thalamus anterior default mode network connectivity, even after we adjusted for social disadvantage. So this is really a sort of a unique impact of prenatal crime. She also found that our other latent variable, psychosocial stress, was mediating the relationship between violent crime and neonatal connectivity. And so that really is, I think, an important public health message about the importance of really focusing on crime reduction and decreasing crime exposure to promote optimal brain development. And more recently, she looked at postnatal crime exposure and found, that really most children in our cohort, their exposure to crime did not change over time, as these graphs here show trajectories of crime exposure in families that moved. Some did move from high crime to low crime areas, and then vice versa, but not that many. So when she looked at the relationship between crime over time and externalizing symptoms, she found that really it was the crime exposure at birth that was related to the externalizing symptoms along with amygdala thalamus connectivity, but that the violent crime by time interaction was not significant. And so it's unclear if that's because not as many of our cohort moved, or if really just that exposure prenatally is the most important. Okay, so I'm going to switch gears from talking about exposure to neonatal crime to now talking about something that is no longer a crime in Missouri as of February, and that's recreational cannabis use. And what we do know is that prenatal cannabis use is increasing, while the use of other substances like alcohol or tobacco are decreasing use during the prenatal period. And COVID further exacerbated that increase, with even more folks using cannabis during the prenatal period even than before. And I should mention, I'll just go back real quickly, that there are certain folks who are more likely to use cannabis prenatally, and that includes young folks who live in urban areas. And most of the folks that use prenatally continue to keep using during pregnancy, because folks feel like it's relatively safe to use cannabis during pregnancy. And we know that the potency of cannabis, the THC, has tripled, and some even say quadrupled or more compared to about 20 years ago. So we thought there really was a need for further study of cannabis, prenatal cannabis exposure. Now, what's been looked at before has shown that there are effects on the placenta and the fetus, and that there may be some effects on developmental outcomes, things like low birth weight, that could affect the long-term health. But the studies that have previously been done were done at a time when the THC potency was a lot less. Some of the most significant work examining the underlying biology of this exposure has been done by Yasmin Hurd and her group, and have found that there is an impact on gene expression, cell firing, and neurotransmitter release, particularly when looking at preclinical models. Now, when we look at the human brain, we know that there are lots of cannabinoid receptors, and we know that the cannabinoid receptor system develops very early. And so you can see here at the bottom left, all the blue circles represent where there's a lot of cannabinoid 1 receptor availability. And then if you look on the right, in the adult brain, again, this is showing, but the warm area showing where there's a lot of cannabinoid receptor binding. And both of these indicate that there are lots of different areas where there are cannabinoid receptors. So there is a possibility that prenatal cannabis use can be impacting development, and that is what our CUDDEL study aims to find. And it's another collaborative study, including all of the folks listed up there as my investigators that I work with. And you can see at the graphic below that we recruit during the first trimester, get both self-report and urine drug screen information that's to determine exposures. I should say it's we include folks who have a lifetime history, but most of them have used cannabis within the past 2 years for both the cases and the controls, whereas the cases are those that also continue to use during pregnancy. So everybody has a lifetime history of cannabis use in the study. And then we scan the infants at birth, and then we're following them up at 6, 12, and 18 months of age. And so this study is ongoing. So this is preliminary data, but what we have found so far in about the first 80-ish babies is that we're finding cannabis is negatively associated with some of those diffusion measures I mentioned, fractional anisotropy, positively associated with mean diffusivity, which makes sense because those two are inversely related. And you can see a lot of those same regions that we showed previously with a lot of cannabinoid receptors are the areas that are impacted. And then we also found differences in the dorsal inferior cingulum uncinate fornix when we look at it with tractography. So using 2 different methods, one a whole brain method to look at diffusion and another looking at specific tracts, we found preliminary differences between those who were exposed prenatally and those who were not. Similarly, when we looked at functional connectivity and prenatal cannabis exposure, we found, again, cerebellar, hippocampal, and amygdala connectivity were different between those who were exposed and those who weren't. And this is showing the areas that were significantly different cases minus controls. So these are the areas that had increased connectivity in the cases compared to the controls. So overall, with the 3 studies we've reviewed for you, we've shown that there are relationships between various social determinants like poverty, preterm birth, as well as substance use exposure on the developing brain, and in some cases with subsequent child psychopathology. So I'm going to switch gears just momentarily to talk about the other side, and that's how we address these things clinically. And so even though I am a child psychiatrist, about 10 years ago, I started the Perinatal Behavioral Health Service. I think that child psychiatrists understand very well how important the caregiver is to child development. And so promoting caregiver well-being, we thought was very important in order to improve child well-being. And so this just lists the mission, vision, and values of what we refer to as PBHS. And our organizational chart, we have several therapists and social workers and psychiatrists, some are child psychiatrists, some are general psychiatrists that work with us. This just gives you a sense of where we are within our medical center. So on inpatient, we're both on the postpartum and antepartum units, as well as at our children's hospital. We're embedded in the cardiac ICU, the neonatal intensive care unit, and with our pediatric neurologists, and as well as working with our fetal care center. And then on an outpatient basis, we are embedded in our OB-GYN clinics, and we joined with our OB colleagues and started a perinatal substance use clinic. It's mostly focused on those with opioid use, but we treat folks with other substance use as well. And then we take a lot of community referrals, both from the Illinois side as well as from throughout Missouri. And so we think by providing this kind of comprehensive care, in addition to mental health care, we do a lot of referrals to a whole host of agencies in the community, whether it be for housing, food assistance, WIC, legal assistance. We ourselves have a food pantry within the OB clinic that we started, and we're also a site for our local diaper bank. So we try to really provide a lot of different services that address some of the social determinants that our patients are facing, as most of our patients, again, represent the same population I showed you earlier from the medical center. We've also been fortunate to recently receive a philanthropic donation that allowed us to start the Herman Center for Child and Family Development, which is a sort of both a research and clinical hybrid, where we are trying to research how various clinical interventions, evidence-based clinical interventions, are best paired with the right family, the right child at the right age. We have an infant core that includes some of the PBHS services, as well as some other comprehensive services for the perinatal period. We have a childhood trauma core that works with families in foster care through the Synchrony Project, as well as children who have been abused through our trauma response program. And then we have an early childhood cohort that is looking both at early child parent interventions, things like PCIT and other parent-child therapies, as well as a psychiatric clinic specific for young children. So this is really for children that are 7 and under, and then a research core and an evaluation core. And so through the Herman Center, again, we are trying to figure out how we can implement these strategies within the community, as well as provide resource navigation to address some of the social determinants the families are facing, and determine how we might be best to implement these kinds of treatments. All right, so I'd like to leave time for questions. So I'll just conclude with summarizing that I think we have a lot of evidence from our studies that the social determinants of health are impacting the developing brain, and that by improving some of these, we can optimize brain development, but we really need more intervention research, particularly aimed at the perinatal and neonatal periods. And I think the other thing that is kind of the main takeaway from today is that clinical programs can and should address social determinants to improve health. We need research studies that monitor the impact of these clinical programs, and that's something that we're trying to do through the Herman Center. And I truly believe that mental health advocacy should also include advocating for policies that impact social determinants. Again, if 75% of the health outcomes that we see are because of these social determinants of health, it is, I believe, incumbent upon us as health providers to be advocating for our patients to have better access to the social safety net, or for reductions in things like racism, programs that promote lifting folks out of poverty, et cetera. So I want to acknowledge our participants and families, as well as the Perinatal Behavioral Health Service team and the Herman Center team. And then pictured here is our Wonder Lab. We're fortunate to have a very large, dedicated group of folks of all backgrounds who really enjoy working with our families and are focused on this research. So with that, I'll say thank you and take any questions you might have. And I can stop share.
Thank you so much, Dr. Rogers. What an impressive body of work that you've and your team have accomplished. And as someone who's been peripherally involved in studies recruiting infants, I congratulate you on just the size of your accomplishments with these different studies. I'll start things off. There are a lot of findings very concerning regarding the effects of these social determinants. But the one that disturbed me the most was your comment about the possible enduring effect of early high crime exposure. And it leads me to my question, which is, how much variability do you see in your connectivity measures as you track these kids over time? Do you expect to see them falling into some kind of latent classes, perhaps, that could give you some other clues about determinants of outcomes that maybe you're not as focused on?
I think that's a really great question. We've not really ever grouped our kids based on their connectivity. We've done things where we've grouped them based on their outcomes and then looked at the connectivity. So that's a really interesting idea in terms of how we could potentially group them based on the variability in their connectivity. I will say a couple of things that I didn't say thus far when we're thinking about these changes that we're seeing at birth and what that means for later. So just because we see a difference doesn't mean that it's necessarily going to be a long-lasting deleterious difference. Some of it has to do with the brain really developing optimally for the environment that it's in. And so there can be pros and cons to that, depending upon what later environment you are in. This sort of the structure of our school environments. Some of our kids, obviously, as we all know, don't do very well in that very structured environment because that's not the type of environment they grew up in. But I always tell this story as sort of an example of how that can still, there can still be optimal environments for everybody. So we scan the kids again at ages 2 and 3, as I mentioned. They had to fall asleep in the scanner. And we found that it was the kids who tended to have more social disadvantage, didn't have super structured, super strict bedtimes, who fell asleep most easily in the scanner. And it was those whose parents had almost these extraordinarily rituals at home. And those were the kids that we had the most challenges getting the scans on because they had such trouble falling asleep in a different environment. So my point is that some of these things may mean that certain environments you'll thrive in and certain environments you won't. And it just has a lot to do also with sort of the societal expectations, whether or not folks thrive in certain environments. So I just want to be clear about that. And there's been some other research in ABCD in older ages that have shown that kids who were in poverty have different who do well cognitively and otherwise have different connectivity than those who weren't in poverty and do well. So my point being, we really are going to have to follow these kids for a lot longer to understand what these early findings mean long-term for the development long-term. So I don't know if that quite answered your question, but I just want to be clear that we don't necessarily yet know what all these differences in brain connectivity are going to mean in the long term.
Thank you. I'll go through some of the questions in the chat. One asks about, are you also investigating the potential of essentially dietary factors such as vitamin deficiencies on these same outcomes, and any findings in that area?
So we are getting, we got food diaries, I should say, both for the mom and then for the infant, for the infants over time. We haven't looked at that data yet. We did use the healthy eating index as part of our social disadvantage latent variable. But in terms of getting specific vitamin levels, no, we have not done that. Okay, yeah, I think that answered that.
Thank you. Another question that I'll add to is, as a clinician, when faced with the enormity of these systemic effects and their impacts, do you feel powerless, or do you think that, indeed, this is my addition, that you will be able to identify some positive moderators and mediators that are a path forward to ameliorating perhaps some of these effects?
Yeah, I mean, the hope is that we will find some positive moderators that are ameliorating. We certainly are very focused on the caregiver infant relationship, and so I didn't present any of that data today. We do find that caregiving does have an impact on outcome and brain development, but in our study, it's only once you get to a certain level of socioeconomic status. So, which suggests to us that there is sort of a baseline level of material support that you need to optimally for the diet to optimally develop. And so, you know, we're one study. That's something that will need to be looked at and replicated in larger studies. We're also a site for the Healthy Brain and Child Development Study, which I think will give us an opportunity to look in a more population-based study at a lot of these things as well. But in terms of feeling overwhelmed or powerless, I don't think so. I think if anything, as I mentioned, you know, starting some of the clinical programs that we started, that we've grown, we see the difference that we can make in as physicians that come at these problems, not just from a biological or psychological perspective, but from a social perspective, that we can improve things. I've advocated, you know, at our state house for certain changes in insurance coverage during the perinatal period within our state. So I don't think, in some ways, I think that the knowledge of the impact of the social determinants makes me feel more empowered as a physician to make sure that I'm addressing that, and that we bring that to policymakers, and that we utilize that as part of our clinical care and continue to conduct research. So no, I don't feel as powerless. I think if we all do it more together as a group, we'd be even more powerful, but that's kind of why I'm out here sort of giving this message.
Thanks. Another question relates to your preterm behavioral phenotype, including ADHD symptoms. And the question is, to paraphrase, with the findings that you have relating to ADHD symptom outcomes, how does that prompt us to possibly reinterpret our understanding of the underlying genetics of ADHD, especially in different populations?
Right. Well, I should say that I think that the preterm population is a bit different than those that are not preterm when we're thinking about ADHD. I do there's so much work here, it's going to be hard for me to answer this question. And, you know, we certainly find that there is definitely still a heritable component to ADHD, even among our preterm population, but we still find that prematurity is an independent factor. There's a manuscript, Helen Lillenwall, the first author, that came out from our group about that. We also find that parenting early on can impact executive function development in children. So I think that, you know, heritability is still very important, but I do think that there can still be environmental factors that impact attention and executive function, you know, and manifest at times as ADHD.
Great. Here's another question from a child psychiatrist working with adolescents in foster care with high rates of in utero substance exposure. Do you think, the question is, do you think using different language around brain function would be useful, maybe even pointing to social determinants to help people focus fixes in that direction? I'm not exactly sure what, well, I think the questioner is worried that some of these data showing negative impacts of social determinants may end up feeling limiting to those parents or families so affected.
Yeah, and that's one of the things we try to be really careful about, and why we are trying to, again, think about optimal brain development for particular environments. And then how do we further help folks utilize what they have in different environments, right? And so I think that it is important, the language that we use. That's why I say alterations and differences, and try not to say, you know, more sort of negative words, because until we follow these children longer, and then also take a lot of look at modifying factors along the way, I don't think we can say for sure what we're finding. But on the flip side of that is, you know, I do think that exposure to particularly extreme poverty has deleterious impacts for many, many reasons on the developing brain, but it is not an individual family's fault for that. That's a societal issue that we need to deal with. So on the one hand, I think it's important to highlight that. So as a society that we address it, but it's also important for us to continue to understand what are the things that happen after that continue to promote optimal development, so that we both can help the children and the families that are in poverty now, as well as try to get the society to focus on how we can decrease the number of folks that are impacted by extreme poverty.
Thank you. Going back to your interesting comment about getting little ones to fall asleep in the scanner and what seemed to be a relationship with their at-home schedules. As you may be aware, Tali Barham at UC Irvine has really focused on this concept
Unpredictability.
of unpredictability in
Yes.
early experiences being an important kind of moderator. I'm curious your thoughts about that.
Yeah, we actually, Ashley Nielsen, the postdoc that I showed you, is interested in focusing on unpredictability as part of her Career Development Award application. And we've certainly talked with Tali a lot over the years and tried to think about how we can assess unpredictability. I think it's an interesting concept in the sense of, whether unpredictability on its own is a negative, or if it's the valence of what's going on, like what's predictable and what's not predictable. Abuse can be predictable, right? But positive things can be unpredictable. So I think that it's important that you look not only at sort of the regularity of something, but also the valence of it to determine how it's impacting the dyad and the developing child. I think that too much predictability can also be a bad thing. And so I don't know if there's some sort of inverted U where there's this perfect amount of predictability and unpredictability, because all of us have had kids for whom the slightest change in routine can be very, very distressing. And regardless of their underlying diagnosis or underlying, mental health issue, and that can be reinforced by sticking to very, very rigid routines and not allowing the child to see that they can sort of handle the typical vicissitudes of life, So I think that it's a really interesting concept, one we're going to continue to see how we can measure in our own cohorts, but I think we want to do so in a way that kind of captures a little bit more of this important nuance.
Thanks. Well, unfortunately, we've run out of time. I want to thank you for a fantastic talk, and thanks again for joining us for the Cantwell Lectureship.
Thank you. Thank you for having me. Bye-bye.